Morning, Liam, Monica, Richard. Okay, Richard, you can start first.
Yeah, hi, good morning. Let me share the screen. Um, ooh, can you see this?
Yeah.
Okay.
Oh, it's
Oh,
echoing.
uh, okay. So I've been working on the just like finalizing this study. Um, so this week I got all the people on the study to approve it, except for Victoria. So I just emailed her. I'll wait for her to get back with the conflicts. Um, and then just Dr. Mahalingam, he made some recommendations that I wanted
Uh-huh.
to run by you to make sure that they're okay.
Sure. Yeah.
Um, so one of them was about trial enrollment,
Yeah.
kind of clarifying like what happened. So
Uh-huh.
I actually wasn't super sure myself. I added a sentence here just to see what happened in the second stage.
Mm-hmm.
Is that correct?
Yeah. That's
Okay.
exactly what happened. Yeah.
Okay. So is it fine if I say that? I just want to make sure.
Mm-hmm, mm-hmm.
Okay, great. Um, and then the other thing was he said in the tables that I should kind of like, I guess, fix the tables in terms of like the content they have. So this is a tables about immune related adverse events. And this is like the raw data from the study
Uh-huh.
PDF. And like there are some stuff here I highlighted that I thought were kind of iffy. Like I don't know if I should include everything in the table because some of them like cough, weight loss, dyspnea, hypoglycemia. I wasn't sure if they're necessarily immune related. So I highlighted ones I thought were kind of iffy. Do you think I should take them out or what should I do?
Oh, but this was still reported under immune related?
Yeah, headache, edema phase, edema limbs.
Ah, I see. Immune related.
Yeah.
Yeah, so a lot of it, so this is for all of you guys. As a clinical researcher, how do you report adverse events? It's maybe relevant for Hesong as well, as she's writing DART papers. So the way we do it is when the adverse event occurs, we document it. We as like a physicians, the study coordinators won't do it for you. You are the clinician. You say this is the adverse event, and you grade it. And then you say there's a checkbox. Is this immune related adverse event or not? So you check it. But imagine doing that for every patient and every trial. It's so hard.
Yeah.
So a lot of it is just like, okay, this can be anything, like possible, possible, possible. And that's how it gets reported. So it's just by sheer checking of the investigator.
Hmm.
So what I'm
Okay.
trying to say, it's not super accurate.
Gotcha. Yeah.
uh, all adverse events will be reported anyway, but whether it's immune related or not, it's really pure discretion of the treating physician.
Hmm.
Uh, but I would say, so let's say edema in the face, limbs. It could be immune. Immune can cause that, but
Oh,
it may
okay.
not be immune. You know,
Yeah.
dysphagia could be immune, may not be immune. We don't know. So when you say cannot exclude the immune, it's like 1% chance it could be immune, then you check it, possibly.
I
So
see.
it's not like we're convinced this is immune. So that's why possibly, probably, most likely category. Some trials just say, possible immune reacts, and that's the only category they have.
Hmm.
Uh, so I'm gonna say, ah, it's okay to take out the obvious ones that are not immune. Postnasal drip is probably not immune. Uh,
Yeah.
tumor pain is not immune.
Yeah.
Urinary frequency is not immune. Uh,
Oh,
and then others specify. I mean, it's not specified. That's just how it was, and that's just like survey language. So I would take all the other specified ones out because we're not sure what that symptom really was.
Hmm.
Um, and let's go up. Flu-like symptoms, flu that flushing could be immune, could not, maybe not, just a simple reaction, but it's okay to leave it.
Okay.
Hyperglycemia, maybe just the effect of the dexamethasone, or it could be type 1 diabetes occurring. We don't know, right? So that's why there's a lot of unknowns. Uh,
Hmm.
GI disorder, other specify. Yeah, yeah. So other specify because we really don't know what they are. According to this one, you can take it out. But yeah, other ones you can just still leave it.
Okay.
Yeah, here, general disorder, same thing. Cough could be, it could be immune pneumonitis occurring,
Hmm. Yeah.
or it could be just coronavirus. We don't know. We don't know. Just
Yeah.
yeah.
Okay. If
So
there's a chance.
when you don't know, you assume, you know, is there a slight possibility? Then you keep it.
Gotcha.
Yeah.
Okay.
All right.
So I'll
Good
just take out
question.
the red ones here. Um, and then a similar question for like all adverse events. There were some of them where I mean I guess kind of similar, but I was like I wasn't sure if it like could count for an adverse event. Like a lot of ones down here, like urinary retention, urinary output decrease,
Yeah.
like lip pain, laryngitis, joint range of motion decrease. Like what's the criteria for an adverse event? Not immune related, but just any adverse event. Like can anything be an adverse event?
Yeah. Anything can be adverse event. And
Oh, okay.
actually, there's CTCAE. You can write down CTCAE.
Yeah.
Is like an adverse event book. And
Mm,
that's how you grade it. The grades are
okay.
by the CTCAE criteria.
Yeah.
And then they have list of adverse events that usually most clinical trials use. So
Okay.
yeah,
Should I delete the other specify ones at least or keep those
yeah,
too?
yeah. Other specify, let's delete that because of the
Okay.
same reason I told you. Yeah,
Okay. But like insomnia, pain, mixture, like all these I'll keep. Gait
yeah.
disturbance. Okay.
I mean, if we had that specified as a specific symptom, then we can rescue those. But at this point, it's hard to go back and retrieve everything, and it's
Yeah.
not that important. Yeah,
Okay. Okay. I'll just keep everything else and then just put in the supplement.
yeah.
Um, okay. Yeah. But yeah, that was it for the changes I had to make.
Okay.
Um, and then once Dr. Villaflor gives her conflicts, I
So I think well, do you have her City of Hope email?
yeah, yeah.
Yeah, yeah. Just give her 1 week. Like we're submitting in 1 week. If you have any comments, let us know. And
Okay.
then if he doesn't respond, it's okay to just submit it still. COI, usually people update in many journals, so
Mm,
because we can't wait forever.
okay. Okay. I'll submit on Friday then. I already emailed her a second time, so
Oh, okay.
yeah. All right.
So what journal? Did we decide?
BMJ Oncology.
Oh, okay.
Yeah. It is open access. Oh,
Okay.
yeah.
You guys know open access journals are usually cost two to $4,000 just to get it published. So there's a movement against these rip-off journals.
Oh.
Uh
Yeah, would you prefer a different one or
no, I think BMJ is okay. I mean, there
okay.
are a lot of open access journals can have more higher citation numbers because people have better access to it.
Hmm. Okay.
But
Yeah.
I don't have preference whether it's open journal or not. Yeah, it's okay.
All right. Thank you, Dr. Chae.
No problem. So this is the Nevo Ipi adeno,
Anosystic and other salivary. Yeah.
cystic and other salivary. Yeah. And you're working on the other Nevo, are you working on Nevo metformin or
Yeah. The Nivo metformin, yeah, and the Nivo proliferate. But I really wanted to submit this before
of course.
um the other one. Yeah.
There, three of them are very similar. So
Hmm.
once you get this out of your way, you can work on metformin, then veliparib. It'll be
Yeah.
much easier, and it will be a really good paper. Yeah.
Okay. Sounds good.
All right.
All right.
Nice
Thank you.
work.
Hmm.
Hello,
Oh,
Dr. Chae. Can I go next because it gets really late here and then I'm not able to present?
oh, sure. Go ahead, Aronis.
Let me share my screen. Can you guys see my screen?
It's now I can.
Yeah, so Dr. Chae, as you know that Dr. Wu and Brendan and Dr. Liam was working on this study. So I was given sarcomas. So initially we had like 10 studies, but only four of those studies were included, and four studies were included, and out of these, only one is meta analysis, and the other three are the other three were just systematic review. And then this is the final sheet that I'm working on. So I've extracted all the data, and we have written the abstract for the upcoming conference, and I think it was shared with you. And um, that's it. That's the update on from my side.
So what did you learn so far with the metastatectomy in this group?
Mm-hmm. So, Dr. Sheda, the thing is that you would think that the metastectomy and the overall survival rates are not so good because in the sarcoma, first of all, the treatments are not so good, and it's like not this area has not been worked on so much. But the thing is that actually the overall survival rates are quite surprisingly very good in most of the studies, like uterine sarcomas, synovial sarcomas. They are, I personally think that I would think that they would be lower, but they are like pretty surprisingly good. And also after the treatment, their like lifestyle and the outcomes are pretty good. So that is the one thing that was like really surprising, and something that I was not expecting.
Good. So tumor types, this is what tumor type?
I'm doing sarcomas, and then Brandon is doing head and neck, and then Dr. Wu are doing the adrenal cortex and the other types.
I see.
Yes.
Okay, very good. Yeah, I saw the abstract Dr. Wu showed me. the abstract from the metastetectomy. So great job. Keep up the good work. I think we should work on getting the paper out, and either JAMA or Lancet Oncology would be a good venue for these type of papers. So
Yeah,
right.
we're just this week, by this week, we will be done with all the extra data extraction and quality checks. And then from the next week, we are moving towards manuscript writing.
Good. Very good. Okay, any questions?
No question. Dr. Wu and Dr. Liam were guided me really good.
Good, good. All right, thank you.
Thank you.
Uh, yeah, we'll go to Alan. I know you're in Korea.
I have to check. Right. So I guess I should kind of I can update you on what I have been doing, and
Yep.
I'll just show you my screen. So I've got a lot of the reading done, and then I've been making some edits onto the overall manuscript. And then when I've done all the reading, I guess some questions that kind of came up was that I realized that this was kind of written a few years ago, from what I remember, a year or two ago, and then so I was supposed to update it. And what I was kind of curious was this because while there are a lot of more results coming out, I was wondering if I was supposed to kind of update it on the fact that like it's ultimately it's still in the progress in progress of developing of having a better AI and deep learning system. But a lot of the articles keep mentioning that it's still a work in progress. And so should I be kind of rewording that kind of stuff as I go along in the original manuscript that we have? Is kind of one question that I had. Because the wording that is already in the manuscript is kind of the same meaning that's been being implied in a lot of the articles. I don't know how important that would be to update that. But and then another question I had was a
Wait.
lot of the
Let's
Mhm.
address that first. So
Okay.
wording and so I didn't quite get your question.
So I guess what I'm trying to say is that in the original manuscript, it's explaining that AI learning and AI machine learning is a work in progress, and there's still a lot to do. And then the articles that I've read, ultimately, it kind of states the same thing, but I guess that there were just more studies being performed related to it, and we have these kind of results. And so, should I kind of update the introduction portion about like what kind of studies there have been related to that kind of stuff, or um, can I just kind of leave it as it is?
So introduction is always just the introduction of the field itself. We don't go in
Mhm,
detail about what studies were done. You
mhm,
just lump it together, studies looking at, the response or looking at biomarker have been, growing in numbers, or, there's more interest growing in investigating these issues. That's it. You
mhm.
don't talk more about the results of the reports. Those will be
Okay.
discussed in the main text.
Mhm,
The main text, you cannot leave a single paper out. Like anything that is within the topic you're studying, you have
mhm,
to cite it or at least mention it. You
mhm,
can mention it as a lump. These studies have looked at, or you don't have to go study by study. Um,
mhm,
but your role is to categorize those studies well and then discuss the uh commonalities or differences between those studies and the meaning out of those studies. But the main message is it's all still work in progress. Nothing is perfect. It's still in
yeah.
development. And even if we use AI, AUC is still not perfect.
Right.
And in my personal view, radiomics, as fancy as it sounds, it's not a good predictor yet. We have to still do a better job than that. And that may be, as in this paper, it's written at the discussion, it's maybe we have to integrate phenomics. Phenomics is
Mhm,
very simple. Are you, male or female? What's your BMI? Our phenotype, phenomics,
Hmm.
uh, genomics, transcriptomics, proteomics, radiomics, pathomics, H&E slide, the special analysis between the distance between the immune cells, and maybe our microbiome, like what microbiome do you have? All of those data maybe really needs to be integrated for us to predict things well, because there's also always interplay between all of those. So that's what we're always trying to get at.
Hmm.
And that's how Hezong and Sira ended their radiomics review paper. So there might be a
Hmm.
good model, how to
Hmm.
write a review paper discussion, what's the structure looking like,
Hmm.
all of that. So, okay.
Okay. And then the next question I had was because I've already had these headings put in from who had written it before, and the new articles that I've read have kind of extra information related to the whole AI pathomics portion, such as like it can help identify genomic features, and nothing in the current manuscript really mentions anything about that. Should I include that kind of information as well within the and then just add a new subheading to what we have, or
Mm. Yeah, so that's Sally's working on Imagine AI's uh,
mhm,
identifying genomic features. So just by
mhm,
looking at H&E slide, we can, oh, this patient has ALK fusion. This patient has
mhm,
EGFR exon 19 mutation. So,
right,
it sounds too good to be true. How do you know? Just by looking at H&E slide, what mutation and I'm a little bit disappointed at their performance, because they put so many in what do you call ambiguous, what is that?
ambiguous,
Tell me what
Equivocal.
equivocal.
equivocal,
There's
yeah,
so many equivocal. So I'm like, what? And you kind of disregard equivocals when they calculate their sensitivity, which I'm
mhm,
actually against that, because it kind of hides their true performance. So you can write that in your review paper. You can say, you can be as critical as you can be. Like, their sensitivity, there's kind of don't report equivocals. And in fact, the majority belong to equivocal. Um,
okay,
but anyway, it is um, you can put identifying genomic features, because some are predicting PDL1, but
mhm,
genomic feature could be TMB. Some programs are uh, trying to predict TMB, tumor mutational burden.
mhm,
But PDL1 is immune marker, or some program
right,
are predicting, like, does it have high immune infiltration? But in a way, it's predicting biomarker. So you have a big umbrella prediction of biomarker,
mhm,
and below that you have predicting genomic biomarkers, which is gonna be the actual mutation and the TMB, and then you have immune biomarker prediction, which is PDL1, uh,
mhm,
and or immune hot tumors or things like that. Um,
mhm.
so I would still categorize that like that, and then, yeah, add to your review paper.
Okay. Right. Okay. Right. So I guess I'll just try to add all of that stuff in, and then maybe afterwards just see if I need to remove it or not from the overall
Yeah, yeah, yeah.
review
So be
paper.
careful about so I would choose the journal you're targeting and look at the word max, and be
Hmm.
careful about going over the word limit. And
Okay.
that means you really have to see, you know, what needs to come out, what needs to be, added more.
Hmm.
That's so did we decide on the journal?
No. So I was going to contact Dr. Choi this week to see whether or not if you guys had talked about it from before, but do you by any chance have any recommendations of where I could consider submitting
Liam,
it
do
to?
you do you know if we decided on this or not? This paper?
I don't know.
Okay, if we haven't decided, let's do JITC.
ITC.
Yeah, and then they have a
Okay.
review paper, and we previously published re- proteomics review paper in JITC, right? That was
Mhm.
Uni Choi. I don't know if you guys know Uni, but she wrote the proteomics review paper. Uh,
Mhm.
it's published at JITC, I think.
Mhm.
The impact factor is over 10. Pretty good journal.
Mhm.
So yeah, read those two review papers and look at the structure, and you may learn from it. The Hesong, you can send in your radiomics review paper, and Liam, you can find uni choice proteomics review paper. Those are all good review papers. Um, Hesong, where was your review paper published? Was it JITC?
It was oncologist.
Oh, The Oncologist. Yeah, so if JITC doesn't take it, we can go to The Oncologist.
Okay.
That's a pretty good journal too. Yeah.
Okay. Okay. And so with all the notes and stuff, I'll have some kind of thing done by next week, I think, and then maybe if I can get a chance to talk to Dr. Choi, maybe see if I can work with him to get him to maybe read it over, or at least kind of just update him on what's been happening on this paper for this week. I
Sounds
think
good.
that's what my plan would be. Yeah. And then project wise, that would be it. But yeah, I'll stay pretty late today. I have to present the journal that I was supposed to do about 2 weeks ago, but I can do that after the project. So.
Oh, you can stay late today? Okay, so we'll get back
Yeah.
to you right after we
Mhm.
go through everybody. Okay, good.
Yeah.
All right. I guess Haesong, you're in Korea, so welcome back. Seong. I was
Yeah, thank you. I was confused. It's good to see you, everyone. Hey, I'm here to check with the abstracts for ASCO with pictorials.
yeah, Liam, let's go
Mm,
over that.
Um, I'll show you the two abstracts that I'm on the lead for now.
Okay.
So this one is the, do you see my screen?
Yeah.
Yeah, so this one is the ICI results prediction. So I'll just slowly scroll down. This is the title.
Oh, what
Oh,
checkpoint? Is that the brand, like their model name?
yeah, it's their model. They had it on the AACR abstract too.
Oh, checkpoint PX.
Mhm.
Okay.
Yeah, and we had to trim down a lot of author lists because apparently ASCO only allows up to 20 authors.
Oh,
And before we had 32 for both pneumonitis and ICI response. Dr. Liam went through the list and we cut it down to 20 each
okay.
now.
Okay. So I mean, we can bring them back for the actual manuscript later. Yeah.
Mhm. Yeah. So this is the background.
So here it says late stage chemotherapy patients, the last background. So
Yeah.
why do we use word chemotherapy here?
Yeah, that's odd because they did remove the chemo, right? I think they changed something.
So here, two cohort experimental receiving immunotherapy. What is 12 to 14?
I think this is Institute 2 to Institute 4. So it's Institute 1, 2, 3. If you can recall, they are using patient information from total of 4 institutions, and one of them is us, Northwestern, and they're referring them to I1 to I4.
I is
So it's
pretty
like,
confusing because it looks like 12 and 13, like 14.
right.
Can we use something
Then
else? 3 institution.
I think we used D for AACR, so maybe we can ask, we could go back to D.
Can we just do A, B, C, D?
That also sounds good. I'll ask and I'll confirm with them.
Because I1, I2, I3, it's just so, yeah. So for the chemotherapy patient, I would say late stage res so I would take a patient because your response to late stage systemic therapy, I'll just say therapies, just say therapies, period. Because it's not response to patients.
Right.
See, these are not grammar errors, but these are clear sentence errors. So we gotta pick them up. If
Sounds good.
the response was defined as disease control per RECIST. That's very interesting because we oh because now what it says is you're calling stable disease response, correct? Dale?
I'll have to double check on that with Nate, but yeah, I'll double check that stable disease.
But let's look at the result. Both
Yeah.
confirmed mix-up treatment lines and predominantly late-stage tumor within the experimental data set receiving ICIs. Predicted response with AUC 0.64 was not found to be predictive response to control data set among chemotherapy patients. So I wouldn't call it chemotherapy patient, patients receiving chemotherapy. I would change that. Patients are not chemo patients. Indicating the signature's ability to specifically distinguish ICI benefit. Checkpoint PX also stimulates ICI patients by progression-free survival, 0.7. Okay, that was pretty short results. Okay, go down. Demonstrated the ability to predict the benefit of treatment specific to with response PFS, response and PFS amongst ACM CPNs, but not patient receiving chemotherapy. That the signature is predictive rather than generally prognosed. Non-invasive predictive tool to address shortage of reliable biomarkers for ICI non-small cell, improve outcome for patient undergoing immunotherapy interventions. Yeah, so there's a lot of repetition and unnecessary long words. This could we could trim that, yeah. But I mean, do I have to really correct that at this point? Probably not.
Okay.
So I think I'm okay, but for you guys, this is just repeating what was said in the result and then repeating it again. So, I feel like this is very different from our own abstract where we are very succinct and just, more information. If I was gonna rewrite this, for the manuscript for Seong for your learning purpose, is that we focus on, you know, what 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 does the demographic look like? What is the percentage of all the stage, male, female, age, and what are the therapies they actually received? We want to know about this population before we know the result of the predictability. And break it down like what percentage were CR, PR, SD, PD. There's a lot of statistics that are not, it's just like AUC, here you go. It was good and not good. So I
Yeah.
understand this is abstract. So I understand this is good, but for actual manuscript abstract, it's gotta be better than this, than repeating
Yeah, got
all
it.
these messages. So
Yeah.
things to clarify with Nathaniel is stable disease defined as response for this purpose of analysis or not. If it was, it's okay to leave it like this. If
Okay.
that wasn't the intent, then we should fix it.
Got it.
I don't,
Yeah.
we had 3 teleconference with them and he never mentioned that he put stable disease as response. Liam, do you remember that? Liam?
No, actually, I don't. Because
Yeah.
we were only talking about responders and non-responders, so I guess they put stable disease.
Yeah. So when you say responder, usually you don't add stable disease as a responder. Usually and then that's because when you say response rate, you only put CR and PR in the response rate. You don't put stable disease in the response rate. But for your study, you can define it however way you want. Like in this study, I am defining, and then no one can say anything about, your own definition. So, this is very important. So check on that. Okay.
Yep. Sounds good.
Next.
Just for the demographics, I would just like to add more information that all the list of patients and the demographic info is right now in hold of Picture Health because we don't have the information for the institution's ABC. So we weren't able to get those demographics. But if it were to go to manuscript, I'll make sure that
Oh,
such
yeah.
things,
Of course.
such informations are there. And excuse me for my voice and stuff. I have COVID right now.
Oh,
So
sorry.
if you can't hear me well, just let me know.
COVID. Oh no.
And so this one's the second one, the pneumonitis prediction draft. This one's also on, I guess, an upgrade version of the one from AACR. This is the title.
AI-based radiology model for predicting immune checkpoint inhibitor-related pneumonitis in advanced non-small cell lung cancer patients. Why did you add expanded study? Because it's the second time? Is that why?
Yeah, and the number of patients increased. So it's actually, yeah, it was just from me that since we're using the same concept and same theme from AACR, but with more patients, we are sending this to a different one. I thought that like we had to show why we are doing this again. So I just added that.
And is the title exactly same as before? The AI-based?
No, the title isn't exactly same, but the method and I mean, the method has changed a bit, but I, yeah, it was just, yeah,
So
sorry.
can we change radiology to radiomics?
Yeah, that sounds good.
Is that term used by you or the company?
I put down radiology radiomics first, but I think Picture Health changed it to radiology. So
Oh,
should I
really?
double check with them?
Yeah, because I
Okay.
don't know if they have a specific reason they want radiology, because I think radiomics people, because people are searching for specific terms. They
Mhm,
look for a radiomics paper, they will search all the abstracts by that term.
mhm. Got it. So would it be better to delete this, or should I just leave it here for now?
It's okay to leave it, yeah.
Okay.
So CIP, the second sentence, not only treatment discontinuation, but there are fatalities. People
Mm,
die of CIP, so you have to mention that, not just not treating the cancer, but they actually die of this.
right. I'll add that.
– 220. Okay. Okay. Got that. – 18% pneumonitis, 50%. So among, yeah, I don't think you have. So that's that's, yeah, interesting. 18 of all the toxicities were pneumonitis, but among them were immune related. Is that what it is?
That's what I understood, but I can double check.
Yeah. Because when you say pneumonitis, a lot of it we say it's drug induced. If it's pneumonia, we say it's infectious. So
Mm,
because pneumonitis can be radiation induced, but this group usually don't receive radiation. So
mhm,
if you are excluding radiation induced, then usually it's drug induced.
mhm,
So I think it should be higher than 50%.
mhm,
Uh, or I could assume that the pneumonitis, unless we know there's a clear radiation treatment history in the region that had pneumonitis, then I would argue that all pneumonitis should be treated as immune related. Because everybody here got immunotherapy.
mhm,
Chemotherapy can cause pneumonitis, but it's hard to tease out. Oh, this pneumonitis was caused by chemo, not immuno, because they're given in combination. Everybody, no one got chemo alone here.
Mhm.
They're all potentially immune related. Do you understand? So,
Yeah.
so I don't think we will have any time or bandwidth to do that today because today is the last day. So
Mhm.
I'm okay, but for the manuscript level, we gotta hone down. Like, why is it just 50%? I think it should be like 95%.
Got it.
And as I told Richard, uh, as I told them, this might be just a poor annotation of the treating investigator, because I'm often in that role, just like a checkbox. Is it immune related or not? I don't know. I just, there's just, so it might be just that.
Mhm.
So I'm kind of worried about that 50%.
Okay.
And then, okay,
So,
wait, there's a 50% grade 1. So you guys know what grade 1 pneumonitis is? What is it, Sale?
sorry, I don't have the definition right out of my head.
So you gotta read. You can't just, write it and you don't know what it means. Grade 1 is
Right,
there's
sorry.
multiple GGOs, ground glass opacity. The patient is totally asymptomatic. So what do? We watch it. We don't stop the drug. Grade 2 is patient cough. Patient has symptom, shortness of breath on exertion. So we have to hold drug. Grade 3 is because there's oxygen dropping. Patient has to be admitted now. So I teach this to every student of mine. Grade 3, any symptom that makes you need to be in the hospital setting to be monitored is grade 3. Grade 4 is life-threatening. Where do you put your patient if anything life-threatening happens? ICU. So if pneumonitis causes them to be in ICU, BiPAP, high flow oxygen, go to ICU. That's grade 4. So really grade 3 and 4 are going to be our main interest. So there was no grade 4. So grade 3 was 20%. So that's about right. Yeah, so I just want in grade 5 is, dead. Any toxicity that leads to death is grade 5. Okay, so AUC was 0.7, 0.6. Oh, so what is stage 1 to 3? Is that grade?
Which one? Are
Stage,
these?
yeah.
I think these are still waiting for the results to come,
Hmm.
but I'll check with what stage these are.
So stage 1 and 2, if it's the TNM staging, then I don't know, because these are advanced stage patients only, right? I don't know where stage 1 and 2 came from. They're probably all stage 3 or 4.
Right.
Severe grade prediction was not possible because the sample size was too small. I understand that. Yeah. So I don't know what Nate is trying to do there. There's a need for further research to improve the prediction. Need for further research. I would say larger studies are needed to better train and validate uh some similar models, something like that. Yeah.
Alright. Thank you. So I think we'll be able to come back this afternoon for in Chicago time for the final review after PH with these results and the questions. So these two are the ones that are led by me right now. And Dr. Liam, are you going to show him the Pacific one or? Dr. Liam, are you there? I think he's unavailable right now, but I'll check with him and let you know, Dr.
Hello?
Chae, if
Sorry,
yeah.
I was I'm having connection. Oh, sorry. Can you hear me?
Yeah, we can hear you.
All right. What was the question? Sorry, my earphone cut off.
Oh, I just wanted to check if Pacific abstract should we show that to Dr. Chae or should he wait for the afternoon?
I was just emailing Nate. I just got. Okay. Yeah, Pacific will wait for Nate to get back to us. They're still working on it. So I asked them to let us know when it's ready for review. So I think we'll be okay.
Okay. So that'll be it for now. Thank you.
Okay, Seong, so those are the two papers you're working on?
Yeah, those are the two abstracts for the ASCO.
Okay. So yeah, like I said, welcome back, and it's it's that time of the year. Yeah, I don't think we can work hard without deadline. So yeah. Oh, so are you done with your exam, or are your exam when is it?
Oh, the exams for the Korea Med School KMLE is finished and I did pass both. So right now
Congrats.
thank you. Thank you. So I'm waiting for my graduation at the moment.
Oh, good. Good, good, good. So yeah, welcome back, and yeah, hopefully we'll work on getting you on board soon, and yeah, hopefully you can come to AACR, hopefully.
Yeah, hopefully.
Yeah, yeah, to present all this. So all right,
Thank
keep
you.
up the good work. I'll
Thank
talk
you.
to you if you have to go. I know it's late
Yeah.
there. Okay. Let's take a bathroom break and we'll come back after 5 to 10 minutes. Okay. 여보세요? Okay, I am back. Okay, let's do Haesung.
Can you hear me? Okay.
Yeah, I
Um,
hear you out. Are you
so
okay?
Liam,
You have
yeah, I think I need to be careful. But is Liam there? I wanted to ask about if EAC can be submitted if we have all the ORCID IDs.
We're still waiting for a couple.
Who else is left? Because we have Dr. Ryan, Dr. Sharon. Yeah.
Let me just take a final tally while you present other things.
Okay, yeah. Liam has been helping out with the submission process. So BAC is going to be submitted to lung cancer. We're still waiting to hear back from JNCI for non-epithelial ovarian cancer. I can actually share the screen. Uh, sorry, one second. Yeah, so still waiting on JNCI. We're going to submit to lung cancer. I think you said we're still waiting for feedback for thyroid, vulvar, and small cell ovarian. Dr. Chae?
yeah. So yeah, I have to check. Yeah, yesterday when I checked it didn't come, so I'll check.
Okay. And then I think Patricia has been very busy lately with the abstracts, so she says it's on her to-do list, but I can give her another nudge tomorrow for Claire Sogine and Des Moines.
So when she collects, she'll submit. Well, no, she'll tell you to submit, right?
Yes,
Okay.
yeah, that's all I have for ours. Just want to let you know, so we do have the last trial meeting, like the bi-weekly meeting with Lunit. But today I have this like residency second look this afternoon, so I won't be able to attend that.
Okay. What time
Besides
is it?
that, it's at 4 p.m.
4 p.m.
So it coincides with the the Lunit meetings.
Okay, so Liam and I and maybe Sally can join the 4 o'clock meeting. And it's yeah. Any update from the last Lunit meeting?
Well, we didn't have one last week, and 2 weeks ago it was just updating them on like the upcoming sim meeting, and then they wanted some clarification on like the sites that we're going to enroll.
Uh-huh. Okay. So did Liam give you the things we are fixing after you left the meeting?
Oh, I've asked him if he could update Akiso, and I have not
I'll be
been
sending the email
notified.
directly CCing everybody.
Thank you.
Yeah. So Haesung, yeah, just work on those. Because they gave a lot of comments.
Mm.
Some of them has to be communicated with their Kiso bio. Some of them we can fix it. So, or she can fix it. But yeah, just make sure they are being fixed. Yeah. So hopefully, they're very thorough. If I don't know what you learned from the sim meeting. Like so the lesson is any language or the wording or anything, it's gonna impact patient, enrollment. And a
Mhm.
patient who could be saved, live several more years by being enrolled in the trial, can be just, ineligible or drop out of the study because of, let's say, a silly lipase value. That's just like, I don't care if lipase value is up, even if patient doesn't have any abdominal pain. But if I write patient is not eligible or has to come off because of the grade 3 lipase value, then I regret not fixing that in the last sim. You know what I mean? So anything in the protocol will affect the patient, in their lives. So that's how we have to be really careful. And yeah, and the deviations, we don't want to have deviation. If we find the rule, we want to keep the rule, abide by the rule. But then if we don't want to have a silly rule that's gonna just entangle us, just makes us work for the, for the working sake. So that's why, I really believe great minds, great ideas, they're super important. That's what gives birth to new project. But the people who are actually doing the project has to be very detail oriented, not miss any single, you know, but it's by attending these sims, working with the people who are actually, you know, enforcing the rules, and really work as a team, and knowing what's more important is, it's really a valuable experience. So I hope, Haesung, you learned that during the sim, and Liam as well. So it's time to, make the protocol perfect as much as we can. So work closely with the writer and Akizo Bio and Lunit, and your Haesung, your role with the help of Liam is to finalize the protocol. And for anyone who's working with me on the clinical trial development, it's a great experience for you to write in your CV and your future interviews, because this is a very valuable experience. You only get it at the level of, last year of fellow or junior faculty. Protocol has no authorship. Protocol is protocol, and it's not published. It's only available for the investigators and the sponsor, and no one can take a look at it. It's not a publication, but it's a protocol that will dictate patient care. So it's the most valuable document that you'll be able ever produce. I used to think, well, it's a lot of copy paste, and it's just like, what am I writing here? I don't know anything. That was kind of what I was thinking during my fellowship. But no, this is the most important document. And if you copy paste wrong things, many people will suffer making deviations. Like, why did we end up, having this in our protocol? If you want to change the protocol, another SRC IRB approval takes a very long time to fix anything. For Dark Trial, I wrote amendment 10 times. It was a torture. Okay. So doing clinical trial, designing it is one thing, but actually putting that into execution and work with all the people in the clinical trial team is something else. These are the people who become leaders later on. How do you actually execute plan? You have to be very detail oriented. So hopefully, Haesung, you continue to work on this protocol. Yeah. But for this meeting, I'll try to attend on your behalf. Okay. Next.
Yeah, thank you. I was gonna say, oh yeah, like things like calendar days and business days, like that could like significantly impact how
Right.
trial is performed. Okay, so yeah, so the two main or wait, Dr. Wongi's gonna be here, right? At 10.
Dr. Wu's gonna
Okay.
come at 10 o'clock, right, Liam?
Okay.
Yes,
Yeah, so
I have
I
not
will
heard
just
otherwise.
okay, so I will discuss the pre-TM one when he presents. I will talk about mucinous is ready, by the way, and so I will submit that. I will show you my transplant one.
And just
So
FYI for the BC, I'm just waiting for Christine McLeod. Just one more author needs to send us their ORCID IDs. I just sent another reminder email.
thank you. Dr. Chae.
Mm-hmm.
Oh, do you see this?
Yeah. Let's go over this.
I want to suggest we come back to the title after reading through the text, if that's okay.
Okay, that's
Just
okay.
wanted to get your final approval. So this is what I have so far. The character count is like it's very tight on the character count.
Uh-huh.
So just wanted to let you, yeah, just wanted to get your final feedback.
Hmm. Hmm. Yeah, so introduction, I think you made it more interesting by talking more about T
Mhm.
cell biology.
Yeah.
Methods, okay, results. Is this max counts wise? Word count?
Oh, yeah, it's like, oh, what else do you want me to include? It's like so the limit is to 600, 2,600 without spaces. And so right now it's 2553 or something like that.
Oh. Now I was
But it
thinking
depends on how
for
long
the the recipient number, whether you can put a comma after
Oh,
every digit. Like
yeah, I will do,
579 comma 905. The result, because the numbers look really long.
yeah, I initially put that. I will put it one if I have enough space, but once we put the title, it might be over to
Oh, title
2,600,
is
so we'll
included.
see.
Title is
I
included
haven't
in the
decided
title.
on the title, but without including it, it's 2553-ish.
Oh, okay,
So, but I'll see what I can do. I understand.
sure. Did you specify chronic up on the introduction? Oh yeah, chronic, like
Yeah,
CRGF. And then
yeah.
you're using, because some you use RGF. Is that a combined then?
Yeah, it's combined and it doesn't include hyperacute, unfortunately, because I couldn't find, all the hyperacute data
I
for
see.
every single transplant type. And I
Oh,
wanted to focus entirely on like the cellular mechanisms, which I believe that hyperacute is not significantly involved in that. It's mainly humoral.
mm-hmm. So
I can specify that in the manuscript, but I just thought it was too wordy for abstracts.
2.1%. And chronic was nine. Wait. Combined is 9.5. Acute is 2.1. Chronic is 7.4. Okay. And then you go to among, next paragraph is combined PTM risk. Did you do chronic only with the same analysis? Both,
Yeah, here.
and even after excluding related retransplant, organ-specific analysis, combined AR in kidney transplant showed consistently low, but only CTRF in lung transplant significant. Okay. Okay, I think that's very good and very succinct. Good job. This is a lot of data, but I think you presented it really well here. Excluding PTM related death in PTM cases, significantly lowered combined graft risk, a trend confirmed in landmark analysis. This inverse pattern was seen in lung transplant, but not in pancreas transplant. Maybe because of the small sample size? I don't know.
Perhaps.
Yeah.
This is what we have for pancreas. It's pretty much all insignificant. The total number is 1928 for
Okay.
pancreas.
So this study showed rejection lowers cancer risk in kidney and lung transplants. And that a cancer diagnosis reduces rejection risk. I would say, well, cancer diagnosis post-transplant reduces, yeah, because like maybe put, or you can PTM, you can change.
Do you think it's more correct to say, yeah, I was debating if I should just put RGF,
RGF, rejection, graft failure.
but I
No,
wanted to
rejection is
avoid
good. Yeah,
saying,
rejection is good.
Okay.
Yeah. Implementing enhanced cancer screening for those who are who have not experienced rejection may be considered. Further research is needed to elucidate the underlying mechanism specific to each type of transplant. So this mechanism is a little vague. Underlying mechanism of what?
T-cell mediated mechanisms.
T cell? I would say T cell biology, underlying T cell biology. Yeah, that's better. It kind of starts with T cell hypothesis from the introduction. Yeah, I think it's a great paper or abstract at the, yeah, it's very succinct, nicely written. And what did I say? Start with JAMA?
Yes, you said JAMA.
Yes. Yes, work on JAMA. After you're done with the DART, work on that. I think this has a really big public health impact. And look at the sample size, 500,000 or 600,000 patients. So this is what JAMA and Lancet likes. And it's a privilege that we have access to this type of big data. Because it's usually very expensive to get these data in hand. But yeah.
I've been trying to acquire the international data. I submitted like the form and then I emailed the coordinators, but I still haven't heard back. But we'll see how things go. It said like the turnaround time is like a couple of weeks. So yeah, we'll see.
Okay, but you were doing exactly what Dr. Cheon did, right?
To be honest, she has not been responding, but I Googled and that's the only way to request data.
That's the
So,
only way to respond. Yeah.
yeah.
I'm sure she followed what was on the website. So
Just FYI, I've actually also requested the international data set from Dr. Chisang, so I'll let you know if I hear from him as well.
Oh no, I got it from Dr. Chisang. It's just that it's very outdated. Like it's 2022. The data cut off.
Oh, okay. So we want like a more recent version. Okay, that makes sense.
Hoping, yeah, but FYI, it's only heart and lung transplants. I wonder if they can give us both. It seems like Dr. Chisang only had the lung data.
only lung. Okay. Yeah, we can ask for both. Why not? But
That's what I did, yeah.
Yeah, heart and lung. So that organization doesn't keep track of liver, nothing else, just heart and lung.
Mhm.
Yeah, okay.
The society itself is called ISHLT, which is like heart lung transplantation.
Right, right. And then I think they have a journal too.
Yeah.
I think there's overlap because US patients are registered there and UNOS. I think
Yeah, that's
there's overlap. But I don't think there's way we figure there's no way to tease them out.
right.
But anything you find here, it will be awesome to have a separate paper to validate the findings here with international data set. That would itself would be great.
Yeah.
And then what Dr. Wangi did with does the pre-transplant malignancy affect overall survival? That same question can be asked in the international data. So continue to work with him on that. So yeah, I am very excited about exploring those two key questions. And it's interesting. I guess the fact that I did MPH at Hopkins, it just focused my mind in exploring bigger data set. What is the most biologically relevant question? Uh, it really helps. So same thing applies to you, Hassan. Like any insight you gain from this lab, that how to think and how to get the data, how to analyze the data, and how to ask the right question at the right time. That's what's going to carry on. The project itself is good, and but by the time you are faculty, Ellen, Monica, by the time you guys are faculty, by the time Sally is faculty somewhere, it's gonna be a whole new world that the AI we're talking about might be really like thought of as like really primitive. Like before, I grew up in a time where there was no internet, there was no cell phone. Okay, we would just so can't even think about it, right? So I think this is my age, my time as a researcher full time. But when your time come, you know, I think everything we do will be, you know, very primitive. We're talking about targeted therapy and we're talking about PD-1. All of these were not even during my training, hematology oncology training. We didn't have a single PD-1 drug. Okay. Now everything is about immunotherapy we're doing. So I didn't learn any of this during my training, even like my fellowship training. So by the time you guys come out, there will be a whole new set of like mRNA vaccines. We might be curing cancers with mRNA vaccines, okay? So we might be totally different era. But what you need to gain out of our lab experience is how to think, scientifically, how to analyze it, how to get the data, how to work with other people, how to implement trial that can actually save lives. So how to think like a scientist and a clinician at the same time. So I really want you guys to learn that and practice that because all the knowledge you gain will be obsolete in 10 years. So AI, we're just scratching the surface with AI. We're talking about AI, but it's just really right now it's in the stone age for AI. That's what I think. Okay, good job, Hasong. Anything else?
Yeah, I actually want to ask if you think it's necessary to break this down by PTM type. Do you think it's helpful?
Yes.
Another thing is these percentile is out of the total number of recipients, but do you think it's more correct to do it as like like divide the number by total of PTN?
Oh, I see.
Because PTN is 12%.
Because it adds up to 12, right?
Yes.
So including breast, GI, where's lung?
Lung, I put it in respiratory.
Oh, respiratory.
These are all like NIH cancer, like system, like system, like a cancer type by system. So it's like NIH official.
I think it's fine.
And then another minor thing I wanted to mention here, this is the rejection-free survival among patients with PTM. If you look here, so without, including all the death cases, like overall, you see like an inverse correlation, but if you break it down by years, it's not, I would say unclear, but once you exclude deaths, you see a clearer like inverse relationship. The thing is, the last 20-year landmark is not found to be significant, so I only mentioned 1 through 15, and that's what I have here. Is it okay to kind of say it this way? Or, like, do I need to mention that it's just up until 15 year, like year 15 landmark?
Oh, I see. I think it's fine because it's so many information. And it's hard to describe exactly what it is. Well, in the landmark, well, at least in the landmark, you can say that range of landmark you looked at, because I think at least you can do that.
I put it in methods. Is that
Oh, in the
okay?
method.
Yeah.
Okay. You can, in the landmark analysis, like you can SES, you can put analysis, the SES.
Oh.
Yeah. Yeah, and the same here in landmark analysis, because you did it in
Oh.
multiple points. Yeah, good.
Okay. And then I just wanted to decide on the title. On the submission guide. Oh, and well, for the author list, I contacted Dr. Shin, Dr. Choi, and Dr. Bra, and they all gave me a thumbs up.
Okay.
And then for title, on the submission page, it says titles should not allude to a result or conclusion.
Uh-huh.
So basically it needs to be more of like a overall, like vague, I guess, title.
Mm-hmm.
And to save word count, I just thought of maybe something like this. The rest is a bit wordy, and I'm not sure. It's not as interesting.
Hmm. T-cell dynamics in organ transplants, graft rejection and cancer suppression. T-cell mediated rejection and cancer dynamics. T-cell mediated graft. Interplay investigating protective reduced. Oh. Yeah, so I like one or two. T-cell dynamics might sound, it might just convey different
Yeah,
thoughts.
more
So
like basic lab kind of thing.
yeah, so T-cell mediated rejection, and I would say cancer maybe risk than dynamics. Dynamics might sound like it's not a common word that we use after cancer. So T-cell mediated rejection and cancer risk in organ transplant.
Can I take solid out?
When you say organ transplant, people usually think about, because bone marrow is bone marrow. We don't call
Yeah.
bone marrow transplant organ transplant, right? So it's
Right.
okay to take it out. Yeah, it's
Okay.
okay. What's the max of the title?
Oh, it's all included in the 2600 character count.
Also, it can be longer. Because like you could, some go down to your method. Some people like to add like, like semicolon and say analysis of
Mm,
579
mm,
organ recipient, something like, that this is like analysis of UNOS OPTN? No, analysis of these recipients. Well, some people like that because that just really draws attention. Like, oh, because just reading it, this might be just like a preclinical, biology paper, right? But then it's not.
like organ transplant recipients, if we have the enough character count,
Yeah.
something like that.
And here you put the comma.
Oh,
Yeah. Yeah, that just grabs attention. Like, well, how did you like analyze that many
Mm.
patients, It just grabs attention.
yeah, my computer was about to blow up.
Yeah, I really like the title. Good.
Thank you. And then for tab, this is Stas has made an update video if you want to watch. Should I?
Yeah, you can.
Oh yeah, okay. We're trying to submit it to Asko.
Yeah. And then can you do optimize to video or something?
Oh,
In
yeah.
Yeah.
Mm,
I'm on an inpatient medicine rotation that is keep me very busy. So I wanted to give an update on TAP. First thing I wanted to go over is to just show you how the files in the Lens or Tempest workspace are organized. So the way that Tempest does it is it takes all the patient's data, clinical, molecular, etc., and organizes it in a collection of CSV kind of Excel sheet files. And some information in these sheets overlaps between sheets, some is unique to certain sheets. So for example, patient CSV, and I'm just looking at the adeno cohort. Patient CSV, if I open one of these files, you'll see some of the information here. All these files are linked by various IDs. So for example, patient ID, which is unique to each patient. Here we have 189 patients. And in this patient.csv sheet, they store information like gender, birth date, death date, and that's it. As well as, actually, there's more information. So then if you look at outcomes here, you'll see other pieces of information. For example, response, lymph node kind of state, stable disease, that sort of thing. And each one of these correlates to patient ID. So for example, these are all the same patient, but this patient underwent multiple different kinds of procedures on, let's see if they have a date here. See, they don't have a date here. For other patients, they do. This is one example of an issue with the way that the information here is organized. Is for some patients, it's very well curated. For other patients, it isn't. And so I've gone through and tried to pull information that is important for stratifying the patients and figuring out if there's any relationships. So I've created this sheet called patients with an uppercase .csv. And here I've organized information about the sex, the birth year, the date, death date, if it's present, the race, the diagnosis date, the diagnostic stage. I've calculated overall survival. This one has been kind of tricky because for some patients we have a death date, for others we don't. For those that we don't, we're kind of forced to estimate an overall survival based on the date that this data set was generated, which was back in August of 2023. Then the first line therapy start date, the first line therapy end date, the progression-free survival of that first line therapy, the allele frequency, the TMB. And so I know that this data set is supposed to be only first line immune checkpoint inhibitors, but there are quite a few patients who have chemo as their first line. And even when I go back and I look at the dates, they may have gotten immune checkpoint inhibitors later in their course, but the chemo comes, or at least has an earlier date associated with it. Let's see if I can find another one. Here's another one. Anyway, and so what I'll show you a little bit later is how many patients have first line of a given type, ICI or chemo or something else. As you can already kind of tell, it's predominantly pembro. And so one other thing I wanted to mention is that allele frequency and TMB come from, this is labeled allele frequency. This is actually math, which is a mutant allele tumor heterogeneity score. That's not important at the moment. For all the molecular stuff, the data is organized in a separate collection of files with this prefix G underscore. And so you can get TMB, tumor purity, RNA expression, MSI, and a lot of other information. All right, now to the presentation. So let me just make this smaller. Okay. So I first took a look at adeno and tried to give kind of an overview of some of the characteristics of the data set. Has 189 patients, average age 73, and this is the stage breakdown. Then when you just look at the first lines without filtering for anything, 109 are pembro, which is the most, it's kind of the predominant one. And then you have a lot of chemo, you have Nivo, and then you have other things like the first therapy was levothyroxine. That's something that I will show. You can basically remove and then it'll move to the next line. The way that this data is organized is no matter what medication they got first, that's considered the first line, even if that medication isn't a chemotherapy. Now, if I filter for only those patients who have start and stop dates, as well as molecular data before the start date. So we know that the molecular data is based on the patient being off treatment or treatment naive. We get less patients, pembrolizumab 55, and then so on. And then if you look, and I wanted to also give you an idea of some of the progression-free survivals for these different therapies. So pembro, the median is 4.74. Then Nivo is 2.67, and so on. I did a similar analysis for squamous. Here, the data set is a little larger, and there's significantly more chemotherapy first lines versus pembro. And then the same sort of thing, filtering for those patients with a start and stop dates for their therapies and molecular data that was obtained before the start date of the first line therapy. So going through this, I start with adeno. I looked at 55 Pembro patients who were curated based on first line, had molecular data before the start date. And so the cutoffs I found that did yield a statistically significant relationship between high and low math groups. Again, math is mutant allele tumor heterogeneity. This is based on allele frequency and how much allele frequency varies across the distribution or across each patient. So I found that across the range, setting TMB, a TMB cutoff between high and low at the 15th percentile through the 50th percentile while keeping the math or intratumor heterogeneity cutoff at the 75th percentile, I was able to kind of get a continuous separation between these groups with improvement as I increased, or not improvement, but better separation as I increased the TMB cutoff from 15 to 50th. So here, what you're seeing is that the low heterogeneity, high TMB group does better than the high heterogeneity, high TMB group. Or put it differently, amongst high TMB patients, those with low heterogeneity do better, and those with high heterogeneity do worse, which kind of matches our prior assumptions about how heterogeneity affects outcomes. Next, unfortunately, I want to mention I didn't look at, I looked at squamous and I wasn't able to find any cutoffs that yielded any sort of statistically significant relationships, even at very small sample sizes. The next thing that I did is I tried to increase the number of pembrolizumab patients who had start and stop dates, and looked at, and not just pembrolizumab, but all immune checkpoint inhibitors. So what I did was I looked at other sheets that I kind of went through all the other sheets that Tempus provided and found places where they mentioned dates of progression or dates of adverse events and used those to estimate a stop date to the therapy to then calculate a progression-free survival. I also removed medications like Levo. Let's see, there were a few other ones here. Zoldronic acid I removed, and what else? Denosumab I also removed. Anyway, I tried all sorts of combinations, all ICIs, just Pembro, all stages, just stage 4, and found that the only, or rather not the only, but the best separation at the highest sample size with the lowest p-value was generated by just Pembro, basically filtering for patients that were stage 4 and just received Pembro as their first line. On the left, I included a similar chart too, or a similar table to the other slides, just to give you an idea of what the total breakdown of therapies was once I increased the sample size by calculating more progression-free survival values. So here, even though this is still amongst high TMB individuals, there's actually a switch based on compared to the switch in the trend compared to the previous chart that I showed. So here, amongst high individuals, those with high heterogeneity actually do better than those with low heterogeneity. And these are much higher sample sizes, so presumably this is a more robust and more likely to be real trend. The actual cutoffs are not that different from the previous charts that I showed you. Here it's 15th for TMB, 75th for math, 50 for TMB, and 75th for math. Here it's 25th for TMB and 50th for math. So the median. Cutting math at the median yields this relationship, which is actually for the purposes of kind of presentation and cutoff selection is pretty convenient. And the p value here is 0.016. Anyway, just something to think about. If you think that this is worth including and not a false positive result, I can then generate a table for the abstract deadline tomorrow or today when you're watching this. Let's see what else I wanted to point out here. Feel free to pause and, look at this more closely and ask questions, and then I'll watch the recording and get an idea of what gaps there might be and what other questions you may have. Yeah. So the next thing that I did is I looked at the distribution of driver genes or driver mutations across both of these groups. So here, 2 pie charts. The one on the left is for it says high allele frequency, but high math group or high heterogeneity group, and the one is low heterogeneity group. The percentages correspond to what percent of patients within each cohort carried each one of these or mutations in each one of these respective genes. And then all the way to the right, I compared the progression-free survival between patients with specific mutations, and was curious to see if there were any statistically significant differences. So TP53 was statistically different with a very, very low p-value. In the high heterogeneity group, if there is a TP53 mutation, patients actually live a lot longer. While in the low allele frequency, or rather low heterogeneity group, again, this is amongst high TMB patients. I just want to emphasize that. Those with TP53 mutations have a shorter progression-free survival. So 5.5 months versus 2. And mutations are present at pretty much the same frequency between the groups, which I think is kind of an interesting finding. I can't explain it, but it is interesting. And then the next significant gene is MET. So MET here is present at 5% in the high heterogeneity group and about 9% in the low heterogeneity group. And again, has about the same progression-free survival difference as TP53. 5.6 months versus 2.03. It's possible these mutations are present in the same patients or not in the same because they're different frequencies, but if there's a TP53 mutation, it also may have or if there's a MET, there is also a TP53. That's how I make sense of maybe some of these similar values. Something I want to confirm because they're too close, in my opinion. And then the last gene is KEAP1, which 8% in the high heterogeneity and 10% in the low heterogeneity, 5.68 months versus 1.61. And just want to emphasize that the sample sizes between these two, 27 and 22, pretty close. That's it for everything I wanted to talk about. Tomorrow I will confirm. I want to confirm that this is real and this isn't like a coding error. But overall, I think there's some interesting findings here. Let me know what you think. And then I can put together a table for the abstract submission before the deadline at 10, I think 10 or 11 Central Time. All right. Again, sorry I couldn't be there. Hope everybody has a wonderful week and looking forward to your feedback.
Okay, I will give some feedback. I think there are things that I really want to clarify and go more in depth looking at the data set, but for the pure purpose of writing abstract and submitting, I think the findings are interesting enough. First I thought there may be some like real drivers like EGFR ALK driving this, but it's not. It's still the two groups look very similar in its distribution. And I think it's important to describe the distribution of the driver mutations. And I don't know with the lower sample size what it really means, but still, I think it's interesting to show the median progression-free survival here. So I would say the largest sample size of 80 and this pembro alone, and I actually have to figure out why the main result switched from higher heterogeneity to lower heterogeneity. So this is the pembro 80 patient data with the high math so high heterogeneity with the median cutoff showing better survival outcome. So it says survival probability and it has median PFS on the left side. And I'm asking you, Haesung, do you know if this is OS or PFS? Is this PFS? Everything is
This is
PFS.
PFS. Yeah,
There
this is
any
PFS.
Is there any OS graph he
Yeah,
present?
the thing is, there just weren't enough death dates, like recorded death dates, and so we thought of replacing the missing ones with like the data entry date, which was August 2023. But that didn't yield any significance. And we also felt like we were playing with the data too much.
Oh, okay, so you guys looked at OS, but it didn't yield any significant changes
Right.
in outcome.
And
Okay.
and by the way, these are all stage 4 adenocarcinoma who received pembro with high TMB.
Right, and these are combined, right? Mono and combo combined? Or is it mono?
That is, I'm not exactly sure, but it seems like what he's saying is these are mono.
Mono.
Because these are only the first line therapies, and if it were combined, I believe that they should have recorded like both types or 3 different types of treatments, but there are many things that we just have to assume in this database.
Okay. So that's really important in the method. If this is really mono, just say it's monotherapy. If it's not, figure out and ask.
Of what gaps there might be and what other questions you may have.
Sorry. Okay.
So I would say, yeah, clarify that. If you have to clarify that with Tempest, that's important. Write that in your method. And here, higher heterogeneity has better progression-free survival. And that kind of is in line with I think it was the Cell paper that we reviewed before, the preclinical basis of how heterogeneity affects the immunotherapy response. It's nicely shown in melanoma cell line data. Haesung, do you remember? That we did a journal club. I think it was when Myungwoo also was around to present.
I remember presenting it myself, but that one, in that paper, I believe the result was reverse. High heterogeneity was associated with poor response and survival.
Yes, but this is the opposite.
Right.
But then the prior one, the graph one before, can you show me? Yeah, this one is showing high heterogeneity showing worse outcome. And if you look at TMB, 15th percentile, 50 percentile high. So I need to understand how this flipped. How, like, I guess the difference between these are all PFS graphs. These are all first line Pembro.
Yes, these are all pending.
And then this is 55 patients data versus the below is 80 patient data.
Yeah.
But I'm thinking 80 patient data should be containing these 55 is, I guess the question is 55%. But here is high TMB is defined as 25%, which is different from the other graph, they use 50%. Can you go back? So and 75%. Oh, no, 15%. Yeah. So TMB, if you do TMB 50% as a cutoff, you have 7 and 19 patients in each group. You have TMB 15%. You have 11 and 35 patient in the cut in the both groups. So more patients there. Can you go next page? But if you have 25% cutoff for TMB, then you have 27 and 22 patients.
In this one, he made many assumptions and he went through all the sheets to collect all the missing dates. I'm
Oh,
not exactly sure how, but he kind of briefly explained how he like collected all the progression dates in different sheets and assumed that's like due to Pembro. I think like may not.
Are you
I will have to discuss with stats, but I just feel like this data isn't exactly clean.
Yeah, only thing I can see is that there's a different TMB cutoff. And it's 49 patients out of 80 patient. Can you go back? As opposed to out of 55 that you have with the TMB 50% cutoff, it's 26 patients. And 15% patients, you have 46% cutoff. So because I cannot explain why the curve reversed, preclinical biology is, like Haesung you said, heterogeneity is usually not good. And the presence of more subclones are acting against good immunotherapy response. Which is kind of, what this graph is showing, not the next one. But I don't know because, Stats was describing the next graph as a better, I guess, filtered data with more patients. It shows the best p-value. So I'm not convinced either direction, and I just need to understand this better. And this all could be just a pure random error causing these, because random error makes it reverse. If it is true, even with changing cutoffs, maybe the direction of association may remain the same. But here I see it being reversed, which creates more doubt that whether this is real phenomena or we're just seeing this as a statistical error. Especially that squamous, we didn't see what we saw in the TCGA paper. So I say so the chance of this getting to ASCO is still low, but I think we can try. So this is how I'm not going to advocate for one versus the other. I will probably say that there's, in patients with high tumor mutational burden, tumor heterogeneity affects clinical outcome. That's our message. How and what direction, we're still not sure, but we kind of have an idea that it's affecting something, especially in adeno. And then it might be related to the mutational landscape, maybe. So at the pure description level, that using different TMB cutoff, using different math cutoff, we're seeing different relationship. And then, two groups are different in mutational landscape. So as a pure description paper, that yes, we used this Tempest data to analyze this, and this is what we're seeing. If he can kind of, and then by the different TMB cutoff and different math cutoff, this is what we're seeing. And we'll leave it up to the readers to decide, to make out any meaning out of it. We're just gonna say we see differential correlation. At different cutoff, we see, different association. So it's going to be more descriptive than trying to advocate for one hypothesis.
Which cohort would you prefer then? The first cohort or the second bigger cohort?
So that's what I need to understand in terms of, is the second cohort a trimmed cohort that is making more sense? I don't know. Let's say in this cohort, if Stas uses TMB cutoff of 15, 25, 50, and then using math cutoff as 50% median or 25 quartile, whatever it is, he can work with different cutoffs and present what he sees. So that's why I need him to work on, because it's not about choosing what the better cohort is. It's about making an accurate cohort. Like if I want to look at stage 4 Pembro versus, can you go back to the other graph?
This is just all stages combined.
So this is all stage and Pembro only?
Yes. With like curated start and progression dates. Yeah. So like stricter cutoffs, stricter like definitions of patients.
Stricter cutoff. Well, I guess we don't use Pembro in stage 1, 2, 3. So
Mm.
so I'm gonna leave it up to Stas to decide what's the better annotated cohort, but I will have him do different cutoffs with TMB and math and write that down, and definitely Hasan, you should help him write it. I think it's worth submitting. But low expectation of actually getting selected, but I think we can at least try and maybe have in-depth discussion about this while he has more time during lab meeting, and submit for world long. But for ASCO, I mean, it's in Chicago. You guys can just go and present. So there's definitely that, being a presenter and just enjoying that moment of science together as a group. I think that's a valuable experience to just be there as an author. So I think you should Stats should submit it with Hasom. Yeah. Okay, I'm a little vague because I'm not even convinced, but I think what I'm saying is it's still presentable.
Yeah, thank you. We'll discuss and finalize, and we'll try to check with you before we submit.
Sure. Yeah, I'll be on standby this evening. Okay. Anything else, Hazel?
That's all I have. Yeah, I do have a few things to ask regarding pre-TM, pre-TM, but I think Dr. Wu will present, and I'll just jump in.
Okay. Okay, Monica. Oh yeah, I can't hear you well. Your voice is very small.
Sorry, there's some problem with my microphone.
Oh, that's okay.
Can you hear me now?
Yeah.
I'm really sorry. So this is the first one for pneumonitis. I haven't edited the author list, but I'll do that once Liam comes. And moving ahead with the abstract. Want to read, Dr. Chae?
Yeah, show me the title.
It's the similar title to AACR.
So it can't be exactly the same. Did you change it a little bit?
Not yet, but I'll discuss this with Liam. title along with the author list. For the other one, we did have changed the title, but for this one, the abstract's kind of the same. I mean, not the same, but it's similar. So we haven't come up with any new title for this one.
So I'll say in patients with non-small cell lung cancer, period, in the title. In patients with non-small cell lung cancer. And I would write it out, non-small cell lung cancer, and put that in the parenthesis. Non-small cell lung cancer and in the parenthesis, NSCLC.
Sure.
And then in every part of the abstract, just use NSCLC instead of writing out any lung cancer.
Thank you. We'll have to change this one because Seong mentioned earlier we have a fixed number of authors we can write. So we'll have to discuss this with them too.
Yeah. So did you change words and sentences compared to the AACR
Yes.
version?
Yes.
Okay.
I mean, it's completely different for these, everything below. Just a few word different for the background.
Okay. Oh, only 2 had grade 3 pneumonitis.
Yes.
So few.
Right. I mean, if we look at the patient among 159, there's only 19, so it's pretty low.
Sensitivity, specificity, positive predictive value, negative predictive value, AUC 0.59, accuracy of 59%, potential of radiomic analysis, coupled with AI in use. Okay. Yeah, this is much better than where we were. I just wish they explained what harmonization means.
We'll
Scanner
try to
associated.
address scanner associated variations.
Okay, I think that's enough then.
This is like exact 2,600 words, so there's so less room for changes, but we can, of course, if you think there's something we want to add up, sure, can come
So you
up.
can, like I said, in the background, you can take out non-small cell lung cancer and just start using NSCLC. Same thing, you use CIP in the title, so you can start using CIP and even from the background. You don't have to write it out because you said it in the title. That makes it just more succinct. Yeah.
Thank you.
Okay, next.
To my next one. Yes. So again, have to change the author list, but Dr. Yuri has suggested this title.
Pre-treatment CT radiomics for predicting immunotherapy response. Resist versus IR resist criteria. Very interesting. Good. I like it.
And coming down to the abstract.
$159 patients. $41 patient CRPR. So was there any CR?
There was 1 or 2. That's sorry.
Then you have to write it. What
Oh.
percentage And how many?
Oh, no. I mean, there was more. We've mentioned everything here. Sorry.
No, you combined the PRCR. So
Oh, okay. I got
So
it.
you can say 41 patient CRPR, but in the CR, you have to say how many and what percentage. Right next to CR and PR.
Sure. There's a lot of technical stuff over here. And the ones which is like in light gray, I'm trying to omit these words because this abstract is over the character limit.
Uh-huh.
So if we remove these, which is written in gray, then maybe we can come under our limit.
And Monica, were you able to hear back from Dr. Yuri about
I
those
did not.
values?
No.
Oh,
I mean, I can send him an email again, but he used to be
yeah,
pretty responsive until I don't know what happens to him at the last minute.
yeah, if we can just send another email, maybe we could text him.
Mm,
And did you want to ask about the potential for a third abstract,
yes,
the
I
clinical
mentioned that.
variables?
I put in the table, I put our queries. I put it really short though, so that he can see and immediately reply on. He has not yet, but I'll send him an email again. Sure.
Oh, and like, do you want to ask Dr. Chair about it too, right now?
Uh, that sounds good. I don't know how well I can explain Dr. Chae, but I still have more confusion. But I can give him an example. So the third abstract we were trying to see is when we were running data, we came to, and I've mentioned this previously too, Dr. Yuri figured out some, for example, like for induced pneumonitis, although we're not using it for our abstract at this time, what we can see here is platelet count has a significance, histological type has a significance, BMI has a significance, and likewise we have similar kind of for others, like for immunotherapy-induced pneumonitis, NLR has a role, platelet count has a role. So we do have such kind of clinical values that we were thinking if we could add another abstract. But I still wanted to confirm about the y-axis and how can I interpret this.
Yeah, why is the title resist?
So we were trying to see if he can respond a little bit more, explaining how he took these data out so that we can mention it in the methods and make a third abstract. But I haven't heard from him regarding this.
So NLR, age, BMI, platelets, contribution on what? Radiomics predictability or what? What is the contribution?
So the contribution, more clinical contribution other than radiomix. It seems like the patient who has a higher age are more prone to here, like NLR play. I can go for, let's go for this one. So the higher BMI, the more prone to getting
Yeah, so
radiation.
what is the red value mean? I just need to understand what that is, right? Red value. Those numbers.
These,
One,
yes, that's exactly what I wanted to ask Dr. Yuri about.
it's like a probability of, know,
Yes,
like
yes.
predicting
So,
immunitis, but I don't know. It's
yeah, something.
50% is pretty high. So I don't know what that really means. But if it is in that same concept, and then Dr. Yuri can write that nicely in the method section and explain its contribution in the model. I think no one has ever claimed that squamous versus non-squamous has different pneumonitis predictability. High platelet may cause more or less pneumonitis. We don't know. We don't know. So, if we are going to make this distinction, BMI, histology, platelet, Monica, why don't you make a 2x2 table? Platelet at the cutoff of the upper normal, which is usually 400,000, or you can break it at the median, high-low, or just at 400,000. This is thrombocytosis versus normal platelet. And then just look at whether their radiomic score is is predicting pneumonitis or not. AI model, or you can do just the pneumonitis yes or no, and make that 2x2 table. And if there's any chi-square or Fisher's exact test p-value being significant. Same thing for BMI cutoff of obesity cutoff, or the cutoff at the median. Same thing with histology. You can do it adeno versus non-adeno, or squamous versus non-squamous, and see if anything is, you can report that. And then within that, what Dr. Yuri ran with, according to the model, there's, contribution factors and all that. So I think the clinical predictability of pneumonitis, apart from radiomics, it's definitely a meaningful. That's why we collected all this, Maybe, I don't know, if ABO type, if we had collected that, maybe ABO type may have impact. We don't know. I think history of actual patient getting COVID, or history of recent vaccination may affect it. We don't know. We didn't collect the data. There's a lot of different variables that may still play a role. So that's but yeah, I think there's a room to make this a third abstract if you have time to interact with Dr. Yuri.
Yes, he did mention it previously, like last week. Then he said he wants to do a few more data analysis before he comes to any conclusion. Last week I asked him and he was like, I'm not sure if I have time. I'll try to look into it. But he was like, I still want you to stick to those two. And the third one, if I have time, I will try to help you
Okay.
out. That's all
So
he had mentioned.
yeah, so understand what the y-axis is. Number two, make those 2x2 tables and share it with me and Dr. Yuri as well. And see where we land. Show me the second abstract one more time. I didn't finish the conclusion. So what is the ones in gray?
So this is actually those clinical features which we saw. Dr. Yuri added them as this, like NLR HBMI platelet from the clinical group correlates to this, were found to be amongst the most significant features for both criteria. He tried to summarize the whole abstract thing into a single sentence for the sake of mentioning it, that we've done that too. I wasn't sure if this sentence here in the abstract makes any significance. And if we are able to make a third abstract out of this, we might not even have the need to mention it over here. So I put it as like a query of what should be done.
I see. Yeah, I
And you
think
said we're already over the word limit too, right?
Exactly. If like that's also another thing. If I remove these, we will be under the character limit. But if I mention them, I'll have to make changes above because this is around 3,000 characters.
yeah. I think the clinical variables are not worth mentioning here. Um, in that case, the clinical data, including gender, age, the method, that can come out too. I mean, we collected it, we looked at it, but we're not really reporting it here. So we don't even have to mention that we collected it. I mean, we collected it, but we're not using it for, we're not presenting the results here. So, that can come out. Because that's kind of given. That's everyone does that. Now I want to, and this is for the manuscript and not necessarily for the abstract. I don't want to touch the abstract, but in the manuscript, I am against how this was described. So in clinician mindset, we are interested in what? Response. What's the next concept? Disease control. Disease control or clinical benefit rate includes stable disease at 6 month mark, okay, 24 weeks at least. Here, it was just SD at the first scan, okay? So I don't want to include SD at the first scan and the next one shows progression. I don't want to call that cancer control or clinical benefit. So when you say disease control, PR, CR, and stable disease for at least 6 months. That's usually our definition in many different papers. That's the consensus. Here it's not. Here's SD is just SD at first scan. And that SD could be 19% cancer increase in its largest diameter, some of that, because the 20% is cut off. Okay. What I'm trying to say is, as Dr. Yuri did here, I don't see a value of predicting SD. Here, you're predicting CRPR and SD and presenting to a sensitivity, specificity, AUC based on like SD prediction. And I'm usually not interested in SD prediction. So for the actual paper, I would take out any SD prediction that is happening on its own. Now, we didn't go far as to 6 month 6 month CT scan resist evaluation. We didn't. We just looked at the first scan and maybe second scan just to clarify the IR resist. So we don't know what if that SD is at least SD for 6 months. We don't have that information for our cohort, unfortunately. So I can't use the cancer control. So I would still stick to the response prediction. And you can do the progression prediction. That's fine too. But I don't want to do the stable disease only prediction when it's not even 6 months. We don't have the information. And I would never do just 6 month stable disease prediction. I would just do it in the context of cancer control rate, which is defined as PRCR or ST at least 6 months, all combined. So I think Dr. Yuri just did it because it was in his like 3x3 table, but clinically speaking, no clinician is interested in it. So you would take out the SD only prediction. But for the abstract, it's okay. It's okay. For actual paper, let's make and the poster, let's make that change. Okay.
Okay.
Okay. So those are the two, and there'll be potentially three. So I'm here all day. So come and find me if you get updates. Just come and get my feedback as you get more input. Anything else, Monica?
That's all I have.
Just one more question regarding that. So do you want the third abstract to have the clinical variable predictions just for the immunotherapy response one or the pneumonitis one together, or should they be separate? Or since pneumonitis sample size is so small, maybe we shouldn't report that. What are your thoughts?
So that platelet, was that response prediction or toxicity prediction?
That was for toxicity prediction. I have other one for response.
Hmm. So it depends on how interesting the data is. If there is very interesting prediction for both, it would have to be two separate abstract.
So this one is for prediction.
Of response?
Yes.
Okay. Do you have one for toxicity?
And this one is for toxicity.
Wow, for toxicity, NLR is not as important. But platelet
Yeah.
was.
But
So
he is not very he's not very confident. He didn't sound very confident last time I spoke to him. That's why he wanted some more time to do it again and again.
And the
Maybe
sample
that's the
size is really
reason he's
small, like
not.
only
Yeah, for toxicity, it's only 19.
19.
Yes, that's
that's
also
19 pneumonitis patients.
yes. Immunotherapy related is 19. Total is 22. 22 or 24. But like in the abstracts, we did not take the any other toxicity like I'm sorry. In the abstract, we have only included immunotherapy related toxicities. So that's why we only have 19.
19. So, okay. So for response prediction, people know NLR is a great predictor. So I am not really interested in that. People know BMI plays a role. But let doctor do the, and figure out what our data shows. But we would save that for World Lung. Okay. For the response prediction. I know it's small sample size, but toxicity, no one said anything about platelets contribution on toxicity before. So it has novelty. So if at all, I would work on that for the ASCO. And if any one of all these four doesn't get in, then all goes to World Lung. Sounds good?
Yes.
Okay, good. It's always good to brainstorm, but yeah. Great job communicating with Dr. Yuri. It's not easy to, I mean, sometimes it's just best to do all the analysis by yourself, just like Hesong is doing. Like, we're relying on Dr. Yuri to like do it, like Hesong's relying on stats to do the analysis for the Tempest one. But sometimes we just better to learn and do it. And what Dr. Yuri is doing is not hard. You just have to, it's the same R, the random forest algorithm. And Jisang was here, Jisang ran it by himself. So it's not something that only he can do. If you have enough time and interest in running the algorithm, you can learn it. Yeah, and I feel like, like this is some, new skill set people need, and it's easier than it looks to run AI algorithms. So, yeah, but at this time, we're clinician investigators, and just understanding the depth of the data and what's novel, what's not novel, and is it really doing a good job? It seems like we're just getting at the 0.6 AUC level and can't go any higher than that.
No,
But picture health is getting close to 0.78. Right, Liam? Or are they better?
Yeah.
Yeah.
No,
They
around
have a lot of
depending on the
patient population too, which I did not know. They presented 222.
Yeah. Picture Health was what? AUC 0.6 something, 5? I can't remember what
something
they're.
like that. Yeah.
So it wasn't over 0.7. Yeah. So yeah, it's hard. It's hard. Yeah. But you know, that's a progress. So okay, good job, Monica. We will take another break and come back to Sally and Dr. Wu. And I know Ellen, it's late. But yeah, I will come back.
Dr. Chae, do you think I can present after the break then, maybe?
Oh yeah, yeah,
Yeah, I think that might be a bit better.
yeah. That'll
Right.
be a yeah. Let's do it.
Okay.
Okay, let's do a brief journal club by Ellen. And then, yeah.
It will be very short. So yes, this was the journal that I looked up on, and as everyone knows, we're looking at the immunotherapy and how we can kind of predict everything, and what is really being looked at in order to predict things like side effects, the effectiveness of treatment, and so. I'd actually put in a lot of background information, but I'm sure everyone is kind of really familiar with everything. We're looking at immune checkpoint therapy, checkpoint blockade therapy, and but the problem is it causes adverse events. There's a range of adverse events that you can see with the treatment. And what we're looking for is to figure out whether or not patients will develop these side effects. And so it's to increase patient comfort as well as decreasing medical costs. And prior research was also focused on things like the clinical features or biochemical features, such as the neutrophil lymphocyte ratios, the platelet lymphocyte ratio cytokines, or also the tumor mutational burden. And it was thought that TMB was linked to the adverse events. But they did list that there was an issue with all of this previous hypotheses. There was a contradiction of reports of whether or not these profiles can actually be used. They weren't sure whether or not the cytokine levels were really due to the immunotherapy or if it's just a response from the immune system. And there's also a lot of things that affect the biochemical profiles that is irrelevant to the tumor. And so they were unsure about whether or not it was actually from the treatment. TMB was also an issue as they found it to be a confounding factor rather than it being a factor in increasing adverse event risk. And then also the problems were that the studies were limited to a particular drug, to a particular cancer type. And even with those results, there were conflicting results. And so ultimately, we are still not sure what actually can be used to predict adverse events. And so in this study, as we all know, we're still trying to figure it out. And so this one looked at some factors related to the patients. The study was based on a multi-center prospective cohort study based on a lot of different types of cancers. So we had 670 patients from 9 different centers. There are a total of 24 different types, and as usually the most common one is non-small cell lung cancer. And they found a majority of them were treated with monotherapy as nivolumab, and then the rest of them were showed the not that much high percentage. So with the findings, they found that there were 80 different types of adverse events, and then they'd actually labeled each of the adverse events into different type of categories. So they had two types of categories, one that was labeled based on organ system. So it's by skin, the endocrine system, thyroid, musculoskeletal, GI, and neurologic. And they also based it on severity and also how many they had. And the critical side effects, there were quite a few, but these were kind of life-threatening adverse effects, such as adrenal insufficiency or meningoencephalitis or myocarditis, pericarditis, things like that. And then the flu-like symptoms, as we all know, is kind of just fever, sweating, fatigue, arthralgia. And then yes, we had the multiple where there were any grades or a grade of 2 or higher. The most frequent one, as we can usually see in the clinic as well, is usually the skin as the adverse events, the earliest one being the flu-like symptoms. And they found that the latest, adverse events that appeared the latest were the pulmonary and thyroid related adverse events. And in this study, they found about half, so 300 patients did not actually develop any side effects. Yes, so this is kind of just the table showing roughly about all of the side effects. And
So
the next one.
question. So those 3 control patients were selected from their database? What I don't understand why the control is all 300.
Within the 670 patients that they had enrolled into the study,
Uh-huh.
372 developed adverse events, and then 372 developed side effects. 300 ended up not developing any side effects within the same the study group.
I see. And then so table control is 300. Then out of that 300, well, that's just control. Oh, and
So yeah,
and then that should add up to 372.
it would add, yeah.
So it's confusing because it shouldn't be 300 from, I guess skin control. I guess that's a skin control then. Yeah. I mean, it's
So
just confusing, but now I understand. Yeah, it's just
okay.
Yeah. Okay.
Okay.
Move on.
Right. So this is just more in depth about what kind of cancers there were, the checkpoint blockade therapy that was used, and just what the regimen was, what kind of treatment they had gone before, and also whether or not they had prior systemic therapy or not. But yeah, I mean, I don't think there was anything in particular that was really that stood out. As I mentioned before, it was just non-small cell lung cancer that's the most commonly studied, as well, and also nivolumab was the most often used immune checkpoint blockade therapy.
Right. So we're doing this because for Monica and many people who are doing toxicity, research, these type of papers are getting into Nature Cancer. So, at least we have a model to learn from. Yeah, you continue.
And then just another table just related to the adverse events. And so the control, Dr. Chae, it was just, so the total of 672, and then 372 developed side effects. 300 ended up not developing side effects. So this kind of does make it confusing, but it's just that with the remaining patients, this was the kind of organization of all of the adverse events within the patient group. And personally, I don't think there was anything that significant that stood out within this group. They did again focus on the non-small cell lung cancer. But, and so what they had found was that, as I previously mentioned, they looked at the biochemical profiles of the patients. And so this study again did show that there is some correlation with the biophysical profiles. And so they found that things like the neutrophil count, lymphocyte counts, this ratio, as well as the RBC and WBC counts were associated with the onset in all of the side effect groups except for the critical adverse event group. And so that was also kind of interesting. But when comparing the pre-samples, and this is when it's when the patients were not treated with the treatment, they'd also found that with the platelets, PLR, protein levels, things like this were developed with the occurrence.
Which direction? Low platelet?
It was with high platelets.
High platelet? Are you sure?
It should be no levels. I do believe it was the high levels were associated with the IRAs.
Hmm.
Missed that on
But
if it was
what-
higher level.
can you confirm that?
Yes.
You probably have a paper right with you.
Yeah.
And Monica, you can look at our group, whether our group has that similar association with pneumonitis.
Doesn't actually state how the occurrence is associated with platelet. Oh, it was, yeah, it doesn't actually specify, but it's just that they were associated with the occurrence.
But there's gotta, so maybe go down that graph. PLR is platelet lymphocyte ratio.
Lymphocyte ratio.
So that's negative. Well, the platelet's there, platelet's negative too. So does that mean low platelet means higher occurrence?
Our one has all
It'd probably be below. Should be low platelets are related to the occurrence.
Mhm.
Yeah.
Yeah, so PLR, NLR are same direction. So that's why I asked. Platelet is immune suppressive. If you have thrombocytosis, you die sooner. You die sooner. There's an NEJM paper.
Okay.
All of our cases also have low platelets.
Pardon?
All of our cases also have low platelet count.
Low
or
platelet
associated
count?
with pneumonitis.
Also, you made 2x2 table?
I have not. I quickly checked all those because I have all the clinical features and the data with me.
Oh, sorry. Are you saying the people with pneumonitis have lower platelet count? Is that what you're saying?
Yes.
Yeah. Yeah. Because if you have high platelet, pneumonitis, you need a lot of T cell there to cause pneumonitis, but platelets are coming and suppress T cell activity. So pneumonitis cannot occur. So platelet is important predictor, in my mind. But it goes along with response. You need T cell to attack cancer cell. So if you have a lot of platelet, your tumor does not shrink. So the response and toxicity goes along. It's the same T cells that are in action. So that's why.
Okay.
Okay. And what about albumin? What about protein? What direction? Can you show us? Albumin is higher. And then protein. What about
protein is high as well.
High. Okay. So protein means maybe you have a lot of immune molecules there to be used. Albumin just means you have better nutrition and yeah.
Right.
Okay. Move on.
Yeah, and then calcium and then ALT were seen in the early or during treatment samples.
Can you go show me which direction?
Calcium is also in the EDT, and so calcium.
Where is it?
Not really a strong correlation. And then
No.
yeah.
And what else?
There's AST, and then AST is similar.
ALT is positive. Huh.
Oh, sorry.
I
Sorry.
think
Yeah, ALT.
I
Sorry.
think that's a random error. I don't believe it. I don't know. I don't think it's doing anything. But anyway,
Okay.
yeah, go on.
Yeah. So I was actually, yes, I was supposed to actually specify that. Yeah, but it's on this chart as well. Again, it's specifying what is high within the pre treatment group as well as the early or during treatment stage. And so um, this was the graph showing correlation between either the occurrence or the rate of onset within the adverse event.
Okay.
And then they had also found that there's also certain gene expressions shown in the neutrophil marker genes. And so they had found that there was less gene expression within the IRAE groups compared to the control. So with those without the adverse events. And so, and they had also found that there was less expression within the early or during treatment samples compared to the pre-treatment samples, suggesting that this was also related to the occurrence of the adverse events with the treatment. And so in this graph is actually, it's actually very confusing to understand, but as I mentioned, so they found a decrease within both the pre and the EDP samples compared to the control. And so when you only look, as it gets brighter or more red, we should see that there is a difference between each of the expression. And so there is less expression. And then they'd actually combined it so that so that we can compare within the pre-group of whether or not with the pre and the EDT. And so we can see that in the IRAE group, a lot of them show that there's decreased expression compared to the control within the pre and the EDT. And then when we're comparing from the pre and the EDT of just within the IRAE group, there's less expression in the adverse event group, is how I understood this graph. Very difficult to understand, but yeah.
So these genes are neutrophil markers, and some are opposite, but then
So, yes, some are opposite, but a majority would show.
yeah. So low neutrophil marker. And these gene expressions are done by the from the blood or tissue. Or is it tissue or blood? Where the sample come from?
This was from the blood, I believe.
Blood?
So yeah.
Then what cells in the blood? Does it say?
I don't think it had mentioned. Oh gosh. Expression was. Based on measured the neutrophil cell fraction based on. I think it was just looking at the neutrophils, I believe.
Yeah, I
Within
think
the
from the
blood, yeah.
neutrophils.
Mm-hmm.
Yeah. Okay, so I think they, yeah, got the neutrophil and okay.
And then again, this was just kind of reiterating the fact that within the EDT group, there was even less expression compared to the pre-group. of multiple neutrophil markers. And this was also showing a similar one. And it gets more confusing because it's actually the negative log graph. And so we're seeing that there's less neutrophil related immunity or response or degranulation within the EDT group compared to the true group.
Okay.
And then one thing they actually found was that with the treatment, it causes an upregulation in genes in all of the patients. And so there are certain genes that are related to cytolytic activity, which you would expect it to occur. So it would help with the tumor activity. But there's also certain genes that are activated that are immunosuppressive, which is kind of goes against what we're thinking of as the immune system would be treating the cancer. But this saying that it also causes immune suppression. And so what they were suggesting is that even though if we use the immune therapy medications, well, this is how I also personally thought of it was that the immune therapy drugs would help increase the immune system to react, and so that causes the immune cytolytic cells to increase and then cause tumor treatment, but also causes the immune system to be overreactive and causing the adverse events. And so while this is not directly related to the cause of the adverse events, they're suggesting that the overactivation of the immune system is not really because of the immune therapy drugs itself. It's that the drugs themselves just cause both the immune cytolytic effects as well as the immune suppressive effects within the body. And then when that becomes problematic, that's when the adverse events start to occur. And so it's really, it helps explain sort of the order. They're suggesting a different order of events when thinking about adverse events.
Okay.
Again, was just a similar chart that kind of reiterating the fact that there are certain genes that get certain genes that get affected where it can cause an increased response compared in the patients with the adverse event.
Okay.
And then again, they found that there's allele activation within the patients. And so in particular, there are certain alleles that were associated with adverse events. And so the first one was associated with certain events, adverse events, except for the neurologic and skin related ones. It was seen very commonly within the critical group, and the other ones with multiple, or this one in particular, it actually showed a decreased rate within the immune related response. And so the graphs were kind of more helpful to understand. And so we can see that while all of the other HLA types showed more of an increase, the 54:01 was showed a decreased rate of immune related events. And so along with that, they also found that there's a germline variant where they found that there are different types of the nucleotide variant, HLA types, all related with particular adverse events or immune responses. And they'd also found that there's a specific mutation that is actually a risk factor for developing adverse events. And so it was very commonly seen in all of the adverse event patients, this TM-EM162. It resulted in high B cell count with a low T cell count after starting immune checkpoint blockade treatment. And so they're thinking that patients with this mutation, they're more likely to develop the immune related.
Okay.
And so this also helps clarify. And then the next point that I made was that, as we'd expect, if you have a more of a clinical response, maybe you're more prone for adverse events. And while that might seem true, they did see that there was significant level of co-occurrence, but this happened to be just a sort of a coincidence, because while we're kind of thinking that, as stated before, it can activate the immune system, causing this adverse event to occur. Things like the expressed genes, they didn't overlap. The neutrophil functions and markers, they're all different. The germline variation between the groups were all different. And so what they found that it wasn't actually causative, but they themselves were all regarded as just specific risk factors for developing adverse events. And so while they might occur together, they were not actually linked. They were possibly not linked for occurring. And so that's kind of how it ended up concluding. They found a lot of things that showed some kind of connection between the two. And they found new mutations such as the TNEM162. And they've kind of found that the neutrophil activation was just from the immunotherapy itself, rather causing the neutrophils to increase, then causing the adverse events, rather than the adverse events causing a neutrophil activation to occur.
So the first sentence is the new contribution, but second one is neutrophil activation from the immunotherapy, maybe the cause.
Yes.
So did they show evidence that neutrophil is activated by starting the treatment? Can you show that?
I don't believe that actually. I believe this is how I understood it, as that it ends up activating NK cells expression.
Genes related to were activated upon therapy only in the control group. Some genes related to gene. Although in response to therapy specifically. That's NK. NK. So
Maybe I had understood it a bit wrong.
So maybe go back to that graph, the baseline and early treatment.
Uh,
Yeah, this one.
yeah.
So the way I understand this is in pre-treatment, a lot of these genes were inactivated. But if you go, these are same patients, right?
Mm-hmm.
The column is same patient.
Mm-hmm.
The pre and EDT. Let's say if you look at CCAM8, the blue box, I'm looking at graph C. The blue
Yes.
box in IRAE
Mm-hmm.
turns less blue, means
Yes.
that gene is less suppressed.
Yes.
So, but it's not always like that. The trend, I don't see a clear trend. CD177 is actually the opposite. It becomes more blue.
Mm-hmm. This is
So if neutrophil gets activated by immunotherapy, among the ones that are getting IRAEs, that means the neutrophil activating genes should get I guess well, the neutrophil has to be more suppressed because neutrophil is always like inverse. Well, the neutrophil activity is suppressed. The more neutrophil you have, the less immune side effects you get.
yes.
So here, if you have less neutrophil, yeah. So I don't understand. Show me the conclusion that you cited from. Let me see what they wrote.
Okay. Sure. Maybe I had understood it wrong, but oh, this is kind of what I had understood, where I tried to relate it
Okay,
from.
therapeutic induction of neutrophil-related pathways in non-IRAE samples was not observed in IRAE samples. Okay, so it's the opposite. The neutrophils are activated in ICI as a feedback, more like negative feedback loop, but
Mhm.
this wasn't seen. The neutrophil induction was not seen. This finding
Okay.
suggests that functional activation of neutrophil serves as a homeostatic mechanism against the activation of adaptive immune system by ICB's treatment rather than as a direct cause of IRA AEs. Neutrophil depletion.
So how I had understood it was that ICIs would cause neutrophils to increase, and then the body would try to react by suppressing the immune system. And so that's why you also have immune suppression gene increased suppression express increased immune suppression gene expression. But I think what they were trying to say is that that's not true. Is that the drugs themselves cause both the immune system to be activated while also increasing the expression of the immune suppression gene. So yeah, I think they're just kind of trying to provide a reasoning for the order, sort of the order of activation.
Hmm. So neutrophil is immune suppressive, period. Neutrophil
Yes.
does not go up or down by
Mhm.
giving immunotherapy. Okay.
Mhm.
Immunotherapy may make it go up and down, but we don't know. We don't know that relationship. What here we're trying to find out is people who are getting immune side effect versus not, what's the difference in their neutrophil count difference? Pre-treatment prediction has nothing to do with that. Pre-treatment is pre-treatment. Immunotherapy
Mhm.
didn't do
Right.
anything,
Right.
but we know high neutrophil count means less response to immunotherapy, more toxicity to immunotherapy, less response, and I guess less toxicity to the immunotherapy. Now, if immunotherapy through what kind of feedback loop causes neutrophil to be activated or the numbers to go up, then you are saying that that group is less likely to have immune toxicity.
Yes.
So here, I'm just trying to understand therapeutic induction of neutrophil related pathways. So if you see that therapeutic induction of neutrophils, you're not going to see that in you're not going to see that in toxicity group, because the more neutrophil you have, the less the chance of IRA happening is low. So neutrophil activation is not going to be seen in immune toxicity group. Do you understand that?
Yes. Yes. Okay. Yes.
And we can explain it through many different things: NK cells, CD4 T cells, whether it's direct relationship, indirect relationship, everything is hypothesis. And that's what discussion is here for. They're discussing it. So yeah, I think go back to your last comment. So this is why critical reading is so important.
Uh,
Neutrophil activation from ICB treatment is not seen
mhm.
in IRAE group. Do you get it?
Yes. Yes. Yeah, I might have.
It's not the cause at all. It's the
Yeah.
opposite.
Right. Okay. I'll have to try to
If
re-understand that, read that again, read that part again. But yeah, I think I know. I know what you mean. I think.
wait.
Yeah. Mhm.
Is that I'm getting confused. Neutrophil activation from ICB treatment, right, is not seen. Right. The more
Mhm,
neutrophil,
mhm.
you're not going to see I. So yeah, I think that's the observation, and then we can hypothesize, why is it, is it direct, um and then this neutrophil activation is from ICB treatment itself as an adaptive immune response activation, and it's not that neutrophil is causing a ARAE,
Yes.
or you know
Right. Yes.
it's just through the therapy effect. I think that's what they're trying to say. But
Mhm.
uh, yeah. So why is neutrophil activated in ICB treatment? I think it's a negative feedback. If your immune T cells too much activated, you have T cell mechanism that is or NK cell or neutrophil mechanism that's providing negative feedback. Just like in the hormone negative feedback, same thing. T4 and TSH,
Yes.
it's
Yeah.
that negative feedback loop. Okay, I just wanted to make this clear because
Yeah,
I don't want you
I've-
guys to learn anything contrary to what the truth is. So, but good job. I know this is not easy, but I think you've done great job. But it's just so. But I want to let you know, this is like really delving into patient chart. How do you annotate it? And what do you find? And you get funding to look at HLA, genomic germline variants. You do anything you can to understand the difference in biology. And it's hard. This is not like, straightforward, but we are understanding what it means.
Yes, it took a while to understand, but
yeah. But this is the real thing. This is the clinical question. Like, how can we best predict toxicity? And are one variable more relevant for pneumonitis, colitis? If you break it down, then maybe they're all different. We don't know, but yeah. All right, Ellen, good job. We'll move on.
Yeah.
Thank you for staying
So
late.
yeah, just lastly, just limitations. It was very, again, it's similar to other studies. It's just very limited within the patient group. So this one is just in Korea. There's not enough samples for all of the immune adverse events, and so especially with the critical group, so it's kind of lacking in that area. Other treatments weren't considered, or so what those effects were, or how it affects the whole lab work and everything, and then yeah, how other variants can occur, and then see how that actually affects it. So ultimately, as we all know, it's still a work in progress to figure out what can be used to predict adverse events, and so we still have to keep working on it.
Good. So Liam and Monica and maybe Seong, you guys need to all read this paper inside out and learn and apply it to your discussion, and it's very important. Okay, thank you.
Thank you, everyone. Thank you
Okay,
for your time, and have a good day.
good go. Okay, Dr. Wu, updates.
Yes, so yesterday we shared the abstracts, ASCO2 abstract with Dr. Bharat, and he said it is okay. So I'm now trying submitting the abstract. The first
Okay.
one is pre-transplant malignancy, and I found that the Tariq's abstract has the same name. Is it correct? Tariq shared about cohort C, and the title was same as this one. Was it
Really? What was the
intentional?
title, Liam?
I just want to make sure.
Are we talking about? Are we talking about the dream cohort?
Yeah. Tariq shared the cohort C abstract yesterday night, and the title was same as this one.
Okay.
Okay. Give me one moment. Let me pull up.
Yes, show me his title.
The order was different, but it looks very similar, so I'm not sure.
So the current cohort C title is rethinking eligibility for double lung transplantation in patients with recent history of malignancy.
Oh, it's very similar. Okay.
Yeah.
But it's
So
quartzy. So I think we can keep yours, Dr. Wu, and
mhm.
we can tell Tarek to change it to a different title. We can call it dream study cohorts, dream study and semicolon and calling it in the
I think we were intentionally trying to leave the title a little vague and open and not have like a direct, uh, not directly mention dream.
Hmm.
But if you think that's okay, we can still change it.
So maybe just like what we did with Hesong's data, you can do if there's no eligible the title max, you can do a double lung transplant and then put colon semicolon and then write analysis of 23,000 double lung transplant recipients or something like that. Then that will kind of give people an idea of what this is. Do you understand?
Okay. Yeah, I'll put that together and then run the title by you again later.
Wait,
Okay.
Liam, I think he was talking to Dr. Wu, right? For this
Oh.
Yeah.
I
abstract.
here for this one.
Yeah,
Oh, for this one.
Yeah,
Oh,
like
okay, okay.
23,000.
Absolutely.
Also, I came up with this title, and so I'm just wondering how this happened. But anyways, okay.
Yeah, so semicolon and then put analysis of 23,291 double lung transplant recipients.
Then it will isn't okay. Like this.
Yeah, I would put the DLT in the parenthesis after the double lung transplant and then reuse it. Yeah. DLT there. And then analysis of, yeah, DLT
Is it
recipient.
okay?
Recipient. Yeah. And then put comma after 23. Yeah,
So
I think that's better.
okay. So I'm trying to reduce the word count. It's over about 50. So I'm shortening the method. So
Yeah.
then maybe I can fit the abstract and the link.
Yeah, you can even take out the subgroup analysis because you're showing that in the results. So you can take out the whole subgroup analysis. Yeah, take out that sentence, it's fine.
Okay.
Dr. Wu, also you can replace all the DLTs with like the acronyms.
Yeah. From starting
I
with
wanted
the
to
background, you
yeah.
can replace every DLT.
Okay.
Starting in the title. That should help.
Okay.
Yeah, you have one in conclusion about after
Yeah.
the lung transplant.
Okay. So maybe then it will fit. I think so.
It's also character count without the spaces.
Yeah. So yeah, I think it will fit into the numbers. So do you wanna make another updates?
You can
I
also,
wanted
what you can do is you have 4 digits on the numbers. You can make that 3 digits. You know, that's too long. You don't need the fourth. So for all the numbers, you have 4 digits, make that all 3 digits.
Okay.
all the numbers, okay?
Okay.
Yeah, then that would significantly reduce the numbers. Yeah. P-value is okay, but yeah, everything else just
I think you can also just take out transplant in the 1,870 transplant recipients. You can just say recipients too if you want to see. Yeah.
Okay. Mm,
okay. Anything else for this?
yeah, no, I will update the numbers. And another is metastacectomy. So it is within the word count.
Uh-huh.
Yeah, yeah. So I didn't change other things.
Yeah, I think this was good.
Okay,
This was good. Good to go. Yeah.
okay. Yeah, that's all. And I will submit this topic to the non-small cell lung cancer metastatic section.
Okay.
Okay.
Haesung, did you decide on the section? ASCO submission section?
Oh, there's subcategory. Yeah, I was gonna actually ask you.
Yeah, because that's important.
Yeah, here, let me show. Yeah, I was actually gonna ask here. So this one, these are other categories.
Yeah.
First, what is it like? It's mostly cancers. For the UNO's rejection PTM paper, I was thinking
Hmm?
this and then real world data. I was debating between like epidemiology, cancer prevention. Um,
Yeah, I would say,
yeah.
oh gosh. Cancer prevention. So, we're saying rejection prevents cancer. So it's not quite, yeah, but I guess it it is kind of epidemiology and cancer prevention. So I would put that cancer prevention.
Oh, you would?
Yeah, rather than real world outcomes. Because people who are going to review this will have no idea of T cell biology, and these are people who are like, if you have insurance, then you will have better health outcome than non-insured. These people who are going to review this are more social.
uh,
You know what I mean? But we're that's why I like the cancer prevention
well,
better.
or maybe like here, tumor biology.
That's more like drugs.
Hmm,
Yeah.
hmm. There's also, you can do primary and secondary designation. And so which one would be primary and secondary? Or we can also just have one primary.
Oh, yeah. Cancer prevention, primary, secondary, epidemiology.
Okay.
Yeah.
Actually for the mucinous tempest, project, what I did was I went to lung cancer and
Uh-huh.
then I put biologic correlates as primary and I put the
Uh-huh.
biologic correlates for metastatic as secondary. Do you agree with that?
Yeah. Well, but our cohort, yeah, our cohort has had more local, right?
Right, yeah,
Yeah,
for
yeah,
the
yeah, yeah.
mucinous.
I agree. Good job.
And then there's also like a separate research category, and under that, for the mucinous type, I put biomarkers. Other options were like registry, retrospective, yeah, stuff like that. But I thought biomarkers would be most interesting because we mentioned like TMB, neoantigen burden, PD-L1 status of mucinous versus non-mucinous.
Yeah. So where's that biomarker here?
Here, one second. It's in the submission page. 1 second. Oh, it's so this is a submission page, and in the bottom you see type of research. And for the graft rejection PTM paper, I was thinking like exploratory analysis. Other options are like registry. Dr. Wu's the retrospective is kind of boring.
So this is what project is this you're talking about?
We can start with, I guess, this one I'm submitting for rejection PTM. Who knows?
No, so that would be exploratory.
Mm.
Rejection. That's epidemiology retrospective. Observational. That's observational.
Mm,
Yeah. I'll put observation.
okay. And then for mucinous, I thought biomarker could be interesting. Otherwise, observation.
Yeah, biomarker.
Okay. Sounds good. And for mucinous, I'm gonna put translational.
Yeah.
But for rejection, I'm gonna put clinical.
Mm-hmm.
Yeah. And then for both, I did, yes, they have implications for the care of older patients with cancer.
Mm.
Yeah.
Yep. That's fine. Okay, very good. Very good. Sally, do you have any quick update?
Hi, Dr. Chae. I'm here with Sally in clinic. We're just trying to consent a dream patient who's coming in for a transfusion right now. She has no updates. She does have the variance classification manuscripts for Eileen that she'll show you later in the afternoon when you have time.
Okay. Okay. Then we'll wrap up here and yeah, Sally, and you can come and give me updates separately on whatever you have.
Sounds good. But yeah, we're just trying to wrap up all of our ASCO submissions today. I think we should be okay. The portal does seem to be a little slow, possibly because so many people are trying to submit it right now.
I played with it yesterday and it's been slow since then.
Yeah.
Be a portal thing.
Okay.
Right.
Very good. We'll wrap up here and like I said, I have meeting from 1 to 2, but I will be available. Yeah, for you guys' question. Okay.
Thank you.
Okay.
Thank you.